I think what we'll do is we'll make a slow start, so that we don't overrun as we head into the evening. Um, so welcome to all that have joined us this evening, and thank you for joining us on a Wednesday evening. So welcome to our journal club, which we hold every month. We're really lucky today to be joined by the Homerton team, and we've got three consultants who've joined us to chair this session. Just some housekeeping rules. The session is recorded. Any questions that you've got, please pop them in the chat, and then we'll try to field them sort of at an appropriate time, when it won't be too interrupting for the speaker. Yeah, I guess we'll get cracking in that case. So it gives me great pleasure to introduce the Homerton team. We're joined by three consultants, Mr. Guio, Miss Mock, and Mr. Agarwal, who will be helping us, help guide us through the two very interesting papers that the team has selected for us today. So without further ado, I hand over to the Homerton team.
Great. Thank you so much, Mo. I just want to get the ball rolling before we all descend into silence for too long. So we've got Mr. Agarwal here, who I think needs no introduction. Miss Mock, another one of my consultant colleagues, and we have two of our fellows. And I'm going to introduce one of them, who I think will be speaking first, and this is Mustafa Moran.
Yep. Thank you, Mr. Gula.
You're welcome.
So, sorry. Okay, I'm Mustafa. I'm one of the bariatric fellows at Homerton. I'm going to start my paper about obesity treatment with bariatric surgery versus GLP-1 receptor agonist. This paper was published in JAMA in September this year. So, starting by introduction, about 1 billion people are affected worldwide, and it's affecting our health and economic burden. And as we all know, two major treatments are available at the moment, which is the pharmaceutical in the form of GLP-1 receptor agonist and metabolic bariatric surgeries. Metabolic surgeries are most effective with about 25 to 30% durable weight loss and has safe long-term effects. GLP-1 has about 18 to 25% weight loss. It is effective but needs ongoing therapy. Both of these methods, they improve weight loss and glycemic control. Metabolic weight loss surgeries have high upfront cost, and the GLP is increasingly used, but the maintenance is a little bit costly. So in this study, they compared both metabolic surgery and GLP-1 receptor antagonists regarding their weight loss and cost effectiveness. It's a retrospective cohort study done in the United States using the Highmark Health and the HealthWork network data. Participants were about 30,000 adults with class 2 and class 3 obesity. About 14,000 underwent surgery, and about 16,000 had GLP-1 receptor antagonists. Follow-up data was more than 12 months, and they did a propensity score weighting to adjust the baseline differences, especially in weight loss. Analysis period was during 1 year from July 24 till July 25, and their aim in the study was to compare weight loss and ongoing costs of the surgery versus GLP-1. Exclusion criteria where they excluded patients who had both GLP-1 and surgery, and they also excluded patients who didn't have obesity in 6 months pre-treatment area. So going to the results, first, the cost effectiveness. So they found out that GLP-1 receptor agonists had higher pharmacy cost. In the first year, they had about $2,800 compared to year 2 with $2,448. Surgery had an initial high cost in the form of $3,000, which dropped to in the second year into about $1,100. So the 2 year, if we compare both prices in 2 years in total, GLP-1 was about 63,000 versus 51,000 for the metabolic surgery, which makes that the metabolic surgeries were cheaper by $11,600. Costs in their study were mainly reduced due to pharmacy spending, and they did another subside study which showed their similar results in patients even without diabetes. Going to the weight loss, where the study looked at about 1,200 patients undergoing surgery versus 257 GLP-1 who had 257 patients who took the GLP-1 receptor agonist. They did a propensity score matching, and patients were about 45 to 46 of a BMI. Almost all metabolic surgery patients, they lost about 5 to 10% of the total body weight, and only half of the receptor 1 agonist patients reached the same level of loss. So the average weight loss is about 28% for the surgery versus 10% for the GLP-1 receptor agonist, which means that the metabolic surgery gives about 3 times greater weight loss, even if the patient doesn't have diabetes. They also found additional outcome that the metabolic surgeries, the patients were overall healthier after treatment than the GLP-1 receptor. They had about 25% fewer hospital admission, 27% fewer clinical visits, and 38% fewer A&E visits. Length of stay were similar for both groups. Patients who underwent metabolic surgery had fewer newer health problems like high cholesterol, sleep apnea, heart disease. And this all indicates that the metabolic surgeries help prevent obesity-related diseases and reduces the healthcare use. So going to the conclusion, so this study is the first major study comparing metabolic surgeries and GLP-1 drugs. Metabolic surgeries have much greater and better longer-lasting weight loss than the GLP-1 receptor. GLP-1 only works while stopping them causing weight regain. And many patients stop GLP-1 early due to nausea or side effects, or even due to the cost. Costly-wise, over 2 years, metabolic surgery was about $11,600 cheaper, which makes it cost-effective in about 15 months. And metabolic surgery patient has fewer health problems and needed less hospital care than the patient who took GLP-1 drugs. Going to the strengths of the study, it's a large real-world data set. More than 3,000 patients were included. It had a linked database combining insurance claim and the EHR data in the United States, allowing analysis of both cost and the clinical outcome. It had a comprehensive outcome, evaluated weight loss, cost, comorbidities, and healthcare use over the 2 years. Also, it had a balanced comparison using the propensity score weighting to adjust the baseline differences. It reflects the real-world practice, demonstrates outcomes in the routine clinical setting beyond controlled trial conditions. The limitation of the study include that the follow-up time varied, which may affect the cost and the outcome, especially in the GLP-1 receptor agonist. Weight loss data came from smaller subset, not the full population. The differences in the baseline may limit the generalization. The purpose of prescription in claims data were unclear in this study. And the results are from the United States database, which may differ in other health systems. So the take-home message from this study is metabolic surgeries are superior in weight loss and lower long-term cost over 2 years. GLP-1 remains effective, but long-term use drives ongoing expense. And evidence gap, more than 5 years comparative data, and the quality of life outcomes. And this is a question where surgery shouldn't be as a last resort, but should be considered alongside pharmacotherapy. So to take from this paper, do we continue the United States stepwise approach as GLP-1 to all patients followed by metabolic surgery? Or is it more cost-effective advice to offer them metabolic surgery, and if the patient requires a GLP-1, we give it to them? The current health system, including the NHS, appears to be adopting the pharmacotherapy as the first pathway treatment. We have limited evidence supporting this strategy, and potentially the cost drives us by the pharmaceutical influence, which raises a crucial question about the optimal sequencing of obesity treatment. Thank you, everyone, and we are waiting for you at LIPS at Homerton in November this year.
Thank you very much for a very insightful summary of this paper. Obviously, if there's any questions, please feel free to pop them in the chat. I do want to start with one question, if that's okay, Mustafa.
Yep.
So obviously this is, US study with
Yep.
US costings. How do you think this would stack up in the UK, and do you think the findings are applicable to a UK cohort?
Sorry, can you repeat the question again? I didn't hear it. I got it in the middle.
Of course. So, how do you think that these findings relate to the UK healthcare system, and do you think that these findings are applicable to our NHS?
So these findings, it is a large study. I think it's similar worldwide. It can be applied a little bit in the NHS. The only thing with the NHS are that we are a little bit driven with the cost effectiveness. We have changing the price of the drugs like in yearly basis. There is in 2026, the tablet forms are now coming in, which will change the price wise, and which will change the way we think about how we offer this treatment in addition to the surgery. So I think till we have like a fixed price and we'll see how the upcoming new treatment modalities are in, at that point, it will change the way we think we weigh. It's difficult at this point to say that we are going to offer surgery and not medical treatment or medical treatment without surgery. I think both of them should be combined like an asset. The pharmaceutical part should be as an asset with us in surgical treatment.
Mhm. Mhm.
Yeah, I
Thank you.
think Mo, if I can come in on that, this paper is based on kind of US and insurance-based costing, and the cost of the first year being 3,800 US dollars. Our tariff is already different, more like £8,000. So I do think that it is not quite applicable in terms of real terms amounts, and there needs to be a UK a similar UK study to make it applicable to how we inform our NHS practice. But I think it's a really interesting, obviously they've used everything in the US system. So for their health system, they have found that the surgery is more cost effective. And it may be that even though there will be slight variation here, then we could find the same. And I really find it interesting to look at, what we do on a population level. How do we interpret these findings, and that the go-to of doing medicine first and then surgery as a second resort is not really driven by a cost effectiveness or evidence base, and that's very much if we are to follow that in the NHS, there needs to be more robust study, a head-to-head study to look at that before recommendations are being made. But clearly, the way things are going, I'm not sure the policies are really made with evidence base. But yeah, interesting paper. Thank you for that, Mustafa.
Thank you very much for those comments as well, Miss Mark. I've got a few questions, if I may, from the Q&A. Josie Nicholson says she comments, really fascinating paper. Is it the limited availability of theatre space that's driving the UK approach of pharmacotherapy first?
Well, I don't think it's about the limited availability of the space. Maybe because of the waiting times in the NHS might drive patients to go through to the pharmacotherapy first. We find lots of patients we meet in the clinic now that they're waiting for surgery. When they follow up, they have started already the GLP-1 injections, and they're happy with that, and they're happy to continue with that.
Yeah, I mean, I think it's obviously a lot easier to scale pharmacotherapy, but we've not really reached our capacity. I think we've got more, there's just never been on the agenda of we need to provide X amount of patients with surgery. But as soon as the drug became available, there is a drive from the NHS and NICE to say that actually we need to be providing X number of patients with medication. So somehow I think that conversation is different between surgery and pharmacotherapy.
but yeah, I do think that there would be some limitation, I think, from capacity perspective, and it is clearly not as easy to scale as pharmacotherapy, but really looking at long-term treatments and effectiveness, we really should be aiming higher with doing more surgery in the UK.
Thank you very much. Thank you.
I do wonder actually that we're not really set up in the UK either for a large scale pharmacotherapy. So we can already see how disgruntled the NHS patients are in general about not being able to get their GLP-1 agonists. And there's a huge and a very long rollout, purely driven by level of comorbidities. So I think it's really quite multifactorial in the UK. And even our sort of patients that are coming to see us, they may not even be given GLP-1 agonists through the NHS. They're usually being obtained, through, well, from whatever means possible. Well, you're just going to leave that there.
Absolutely. And I think looking at the financial differences between what the paper suggests that the average monthly cost is and what some of our patients are paying here when they go privately and individually, there's a big difference. Can I ask another question that's come from the chat to the team? So Henry Najuba says, thanks for the great presentation. Given that Ozempic is going generic next year, how do you think this might impact on the study if it were repeated in a few years' time?
Is that just to anybody?
I think so. Yeah.
Yeah. Mustafa, do you want to answer that one?
So the study might affect this year. I think it depends upon if it's gonna be it's gonna be cheaper, expensive. I think this is how the bariatric market goes at the moment. So I think if it's more expensive, I think it's it's difficult to presume at the moment until we know the prices of the medications of next year. But it will still remain more costly because the patients will require long-term usage. Once they stop it, they will gain back. Two-thirds of the patients will gain back their weight as the step 5 trial. So I still think that taking the GLP-1 receptor agonist, that it will still remain more costly than the metabolic surgeries.
Yeah, and the data for GLP-1 isn't that long still, so we don't know what happens if you use that for 5 years and 10 years, whereas we have more than 10 years outcome data for bariatric surgery. So yeah, tricky. I think we need more evidence.
Thank you very much for that. I've got more of a comment that perhaps our panelists can respond to. So aside from the costs, we need to find other benefits to stay in business, is the comment. Any sort of counter comments to that?
There are still revisional surgeries. Patient will relapse. No, I don't think that we need to see it in another business. First of all, like there is a good amount of patients that they cannot respond to the GLP-1 receptor antagonists. This is one thing. There are lots of patients that they can't stand the side effects of it, and there's some patients who cannot, who still they take the injections and still have their high calorie intake. Something that the surgery will always have an upper hand on the restriction part.
Yeah. Okay.
I think also we're much better set up in the NHS to look at the most holistic approach at weight loss. Whereas I think just the use of the weight loss injections or even tablets at that point, unless the patients are going to be able to address all of the other factors that enabled the weight gain to start off with, they're on the back foot. They're not going to be able to make those changes. And I think the NHS is very good at supporting the patients in particular with the psychology.
Mr. Agwar's got his hand up at the moment.
I've got a question for Mustafa. In this paper, I've not read the whole paper in detail, but how many were on tirzepatide and how many were on the older drugs? Because I was surprised to see a big difference in the weight reduction. And there's not much difference between Mounjaro or the newer GLP-1 compared to liraglutide or
So this is part of the paper where they just put the drugs medication.
Did they qualify how many were on which and where was the outcome, or they just blanket covered the whole outcome?
They just blanked the whole outcome. They just mentioned all the drugs that these are the patients they've collected in the previous time with these medications, and they haven't put like a subcategory which medication they have given.
Because the difference between the weight loss outcome between Mounjaro and surgery is not big difference compared to Wegovy or the other older drugs, liraglutide or diraglutide. So yeah, that would be something which we should look at as well. And coming to the other question about I think it's a human psychology and the social media is driving pharmacotherapy as well. And I suspect it will continue for the foreseeable future. Obviously, we all know surgery will be cost effective in the long term, but as we all know, we all don't want to have surgery if we can avoid it, and that's probably the most common reason why pharmacotherapy is being driven in the whole over the world. So yeah, obviously we'll see how time goes. Yeah.
We've got a couple more comments from the chat. So we've got there's just a comment about growing concerns about optic neuropathy associated with the GLP-1 agonists, and the commenter was questioning the future of GLP agonists. And I think if I could just ask one final question then to the panel, what did the paper allude to adherence to the GLP-1 agonists? And in your experience, or to the best of your knowledge, do you think that that's going to be a problem longer term?
They said the patients were adherent to the medical treatment. And on longer term, as I said, it's only 2 years. It's only a 2-year study paper, 2-year follow-up, like from 12 to 24 months. That was a follow-up. We don't have enough data on longer terms. And I think this is something we should look into future. Yeah.
Okay. Thank you very much then, Mustafa, for your paper and for presenting that. I think just in the interest of time, we'll move on to the next paper. So if I'll hand back to the Hamilton team to introduce Al-Mu'taz.
Hi everyone. So we've got our fellow who is Almatas, and he will present the next paper. So he's completed his fellowship at St. George's before joining us here at Homerton, has been with us and is an excellent member of the team. We are very lucky to have him, and he's here to present I think a very interesting paper on GLP-1 use and its impact on eating disorders, which is traditionally treated using behavioral therapy, and I think this new evidence could change the kind of treatment algorithm and how we think about these eating disorders. So over to you, Almatas.
Yeah, thank you very much, Ms. Mook, for the introduction. I'll share my presentation. So yeah, this a paper that I'm about to present visits a different aspect of patient care, which is the eating disorder. We know that the majority of our patients would have some element of eating disorder, either mild or severe. And usually when we have patients with severe eating disorder, we usually defer surgery to a later date, and we refer them for eating disorder services where they receive cognitive behavioral therapy and group therapy and other forms of therapy. And then once they are 6 months free of binge eating, usually they are referred back for surgery. In this paper, we'll see that there are more modalities of treatment that can be used in these cases. So the title is The Impact of Glucagon-like Peptide, GLP-1 Agonist in the Treatment of Eating Disorder. It's a systematic review and meta-analysis. It's published in the Eating and Weight Disorders Studies on Anorexia, Bulimia, and Obesity. This journal has an impact factor of 2.8. It was published by a group of researchers from Tehran University in Iran. So eating disorder is highly prevalent and increasing, and is associated with other psychological disorder like depression and anxiety, and it has a health impact. The most common is binge eating disorder and bulimia nervosa, and they are associated with obesity and obesity-related comorbidity, including type 2 diabetes and others. Now, binge eating disorder is characterized by episodes of consuming large quantities of food, often accompanied by a sense of loss of control and guilt and distress, and is frequently associated with psychological factors such as depression and anxiety. And in UK in general, it's considered a contraindication for bariatric surgery, and patients are usually referred to eating disorder and they are referred back for surgery after finishing treatment and having 6 months to 1 year period of no binging. Now, we have limited pharmacological options for these patients. It's usually cognitive behavioral therapy that is used because we have few approved medications for that, including lisdexamfetamine and topiramate, which has a side effect profile. Now, there is a growing evidence of using GLP-1 agonist in these cases. We know that the GLP-1 is an orexigenic hormone. It's secreted by central and peripheral places, by the enteroendocrine cells in the gastrointestinal tract, and by the pre-proglucagon neurons in the brain as well, which together constitute the central and the peripheral effect of the GLP. Now, the GLP-1 also modulates the neurotransmitter release related to hunger and reward in the hypothalamus and the striatum, resulting in reduced food intake. And also it has to do with the signaling in the homeostatic feeding behavior and non-homeostatic control of food reward. Also, the neural pathways involved in GLP-1 receptor-mediated reduction in food intake include feeding centers in the hypothalamus, the hindbrain, in the mesolimbic reward system, and in certain forebrain regions, including the medial prefrontal cortex. So in this study, what they did, it's a systematic review and meta-analysis. They conducted it following the PRISMA guideline for meta-analysis. The primary outcome of the study was to evaluate the impact of GLP-1 agonist on weight loss and body mass index and weight circumference in patients with binge eating disorder in particular. And the secondary outcome included the impact of GLP-1 agonist on emotional eating behavior, including emotional eating scores. Their inclusion criteria was population problem, original article, including observational studies and clinical trials assessing people with eating disorder with no restriction on age or gender. Studies assessing the impact of GLP-1 agonists with no restriction on route or dosage or using other types of antidiabetic medications. And the control patients, assessing a group of patients as a control who didn't receive the GLP-1 agonist, received either placebo or other medications or lifestyle and diet intervention. And the outcome of the study should be assessing the impact of GLP-1 agonist in the weight loss and also in the change in the weight and waist circumference, and in the emotional eating behavior and the emotional eating scores. Exclusion criteria were any study that doesn't assess eating disorder or not administering GLP-1 agonist, and reviews and case reports and study protocols, or if it was inaccessible. Now, the score that they used to assess improvement in binge eating disorder was the psychology tool used by most of the psychologists, which is the binge eating scale score. It's a questionnaire, comes of 16 questions, scored from 0 to 3. The total score will be anywhere between 0 and 46. Usually, if it's between 0 and 17, it's mild. If it's between 18 and 26, it's moderate. And if it's more than 27, it's severe. And the improvement is based on repeating the questionnaire and seeing how the score will change after treatment. Now, the results, this is the PRISMA flow chart. So they started with 2,931 studies, and they added to that 329 studies from the Google Scholar search, and then they excluded the duplicates, and then they excluded everything that doesn't match the inclusion criteria to end up with 75. And then the 75, they excluded the studies that, after reading through it, the one that doesn't have binge eating disorder or no GLP-1 administered, to end up with 5 studies. The total number of patients in the 5 studies were 182 participants in both the treatment group and in the control group. These are the 5 studies that were included, and they included patients who were on liraglutide or patients who were on semaglutide or dulaglutide. Now, patients who received the GLP-1 agonist experienced a significantly greater weight loss of 3.81 kilogram compared to the other group. This was also applied to the waist circumference and also to the BMI. And also individuals treated with the GLP-1 agonist showed a reduction in the binge eating scale score with 8.14 points greater compared to the control group. If we go to the charts here, we can see that they divided the groups into liraglutide group and non-liraglutide group. These are the patients who received semaglutide and dulaglutide. And we can see that in each study separately, the mean weight loss is reduced by 3.8, 2.6, and 3.6 kilos. and the average was 2.86 kilos. In the non-liraglutide, it was a little bit more, and we can see that in the pool also it was 3.81, and this was statistically significant. This one here is about the reduction in the BMI, the same finding. And this one here is in the reduction in the waist circumference, and it was the same finding as well. And this was in the reduction of the binge eating scale, and the total reduction in the pool was about 8.1, and it was statistically significant. So the discussion is that eating behavior is not passively determined by hormonal fluctuation and energy demands. It's a complex behavior influenced by multiple factors, including central reward processing, food hedonic value, gut-originated reward pathway, and gut microbiota environment. Genetics and cognition plays role. Psychological factors such as anxiety and depression plays role as well. And GLP-1 and this receptor has been located in specific brain regions, as we said earlier, and it can cross the blood-brain barrier as well. So when we administer that, it will have both peripheral and central effect. Researchers have examined the central effect of GLP-1 analog, and the studies have shown that they have beneficial cognitive effect. And also they have positive correlation between treatment and enhanced cognitive restraint score, suggesting potential therapeutic effect also in specific eating disorder management. And this also can help in some addictive disorder like alcohol, nicotine, and other drugs. And modulation of the reward system represent an additional mechanism by which GLP-1 analog may be beneficial in treating specific eating disorder like binge eating disorder. Another study of 69 participants showed that semaglutide was highly effective in ameliorating eating disorder or emotional eating, and it reduced that from 72% to 11.5%. Same effect was in external eating, which decreased from 27 to 10%, and same effect in craving, which decreased from 49 to 21%, and for savory craving decreased from 53 to 14.5%. And this is after 3 months of treatment with semaglutide. So the conclusion, this research emphasized that the importance of administering these medication to individuals with eating disorder, highlighting their potential benefit for weight loss. And clinician must also consider the potential adverse effect, evaluating the cost effectiveness of the medications, and closely monitoring for any improvement or worsening of eating disorder and related side effects. I every now and then meet a patient in the clinic who will tell you that once they started taking the GLP-1 agonist, they became more mindful about what they eat. They just mentioned this word, that they start thinking in a different way toward food and toward the food options as well. And this emphasizes how it does affect the cognitive function and how people think about food and all the reward system and hunger system work. If I would say what are the strong things about this paper, the strength is that it's touching a subject that wasn't touched before, and it will open for future research opportunities in this subject. Weakness, I would say that it's not a randomized controlled trial, it's a meta-analysis, and the number of patients included was low, and the number of studies included was low as well. And it did concentrate in one aspect, which is weight loss, and one aspect, which is binge eating disorder score, rather than multiple eating disorders and multiple comorbidities that do improve with these patients. And we don't know what was the duration also that these patients were followed after, and what would happen if we stop the GLP-1 agonist. And these are all things that we can look into in future research. Thank you.
Thank you very much for an absolutely brilliant talk. Really, thank you to covering the pathophysiology at the start to contextualize the paper. As we wait for the questions to come in from the audience, I just had one from the get-go. In this paper, did they allude at all to how the GLP-1 agonists stack up against established treatments for binge eating disorders?
So in the 5 studies, they compared. It wasn't mentioned specifically what were the medications that were used, and because of that, we can't compare. And also, the number of patients were minimal. The total was the 187, but not all of them received medication. Some of them only received the behavioral therapy. So I don't think we can compare based on this study.
Okay. Thank you. I'm just going to read one of the comments that's popped up. So Josie Nicholson says, the paper did not discuss the effectiveness of CPD for the treatment of BED.
Yeah.
Is that something that
So
you
this wasn't the main subject of it, yeah. So it didn't touch the CPD and how effective it is in the treatment of eating disorder. And for now, it's the main treatment. It's the main thing that most patients receive. The main idea of the paper was to, let's say, highlight GLP-1 agonist as a modality of treatment that can be used, especially that we don't have much pharmacological options in these cases.
Mhm.
Yeah.
Yeah, I agree. I think we need basically, that evidence is not there, but we need a head-to-head comparison of the GLP-1, which is not really an established treatment, not first line for binge eating disorder, which is cognitive behavior therapy still. So that needs to be investigated. It'll be interesting to see the results of that, or even GLP-1 alongside CBT as an adjunct to establish, to the best treatment we have for big med, would be interesting.
Thank you very much. We've got a couple more questions coming through, so if I can just pitch those towards you. So we've got a comment from Varun Aranagiri, he says that great paper, which was really not touched. Is there any evidence of the effect of binge eating after bariatric surgery?
I can answer that, test if you
please.
like. I have a great interest in this because this is one of my PhD chapters is on GLP-1 and bariatric surgery. So yeah, so it goes both ways. Obviously, there's evidence that bariatric surgery improves binge eating scores, but there are also, the other side which says that existence of binge eating disorders and binging behaviors leads to poorer outcomes of bariatric surgery. So it's kind of, I think that's why we are cautious about putting bariatrics or putting patients through bariatric surgery if they've got existing binge eating disorders, because we want the best outcome for our patients, and that evidence has been fairly consistently repeated. But we do see that people with high binge eating scores do improve after bariatric surgery, and certainly, my unpublished data show that actually if you've got low levels of GLP-1, then you are more likely to score higher on your binge eating score. So it's and actually if you improve that, that reduces binge eating disorder. So I think it's a really interesting relationship, and it certainly makes us think, what should we do? Should we really withhold bariatric surgery for people who have binge eating disorders and persist on CBTs, or whether we should do something alongside each other, or that I think that is still needing to be investigated.
Thank you very much for such a comprehensive answer. That's really thank you for that. Can I throw some more questions at the panel, if that's all right?
Yeah.
So I think we've got more of a comment. So from Henry Najuba saying, "Thank you for a great talk." So should psychologists start prescribing medication, or should doctors start managing eating disorders? So I think more of a comment, unless you'd like to respond to that.
I think we work usually as an MDT at the end, and patients are managed by all the bariatric team, which includes an endocrinologist and a surgeon and a psychologist, and we can discuss these patients, and anyone can start the medications for them.
Thank you very much. And then we've got a comment which I'm just going to read out. So it's from Josie Nicholson, who says, "In my experience as a psychologist, binge eating can occur sometimes due to hunger drives, but sometimes for emotional emotions. The GLP-1 and MBS might address the hunger-driven binge eating, but unlikely to address the emotionally driven reasons for binge eating," which I think ties in a little bit with what we were saying earlier. And then we've got a couple more comments. It's often important to understand the reason why people are binging to know whether bariatric surgery would be helpful or harmful. Do we agree? Yeah.
Yeah, I think that's really excellent comments, but it's also, I guess the question is how much is there, what are, how much is this is driven by some underlying biology of low levels of GLP-1, making it easier, as with many disorders, there are multiple hits. You have to have certain, a biological basis, and then you've got other hits, and then you manifest into conditions like obesity and things like that. And so therefore, would an adjunctive treatment together with CBT be more effective rather than focus on CBT alone? I think that's the question here. We don't have enough evidence to say that GLP-1 is the treatment and the only treatment. That's definitely not what we can conclude from this paper, but we certainly can start us thinking about other treatment modalities to make the treatment more effective potentially. But yeah, I agree with what Josie is saying.
And then we've got a really interesting comment from Lisa Rickers, who says, thanks for opening up this debate. I know we have concerns of offering bariatric surgery with BED, but with GLP-1 receptor agonists, we can stop therapy if this increases the incidence. There's a lower risk. So I think that's just more of a comment about the reversibility of GLP-1 agonists. Are there any other comments from the panel after Almortaz's presentation?
Not from me, thank you.
No, me neither. Thank you.
In that case, well, thank you very much all, and thank you for those who've contributed to the debate. Thank you to the Homerton team. That was really interesting papers, really excellent presentation as well. So I really thank you for your time in preparing that and for delivering that. I really appreciate your valuable time.
Thank
you
you.
very much.
Thank you.
Thanks for organizing, Mo. Thank you.
Of course. And in that case, we'll conclude this evening, and I
Thank
wish
you.
you all a lovely rest of the evening.
You too.
Thank you very
Thanks
much.
so much.
Take
Bye,
care.
everyone.
Bye-bye.
Bye-bye.
Bye.